Hello, I'm Simon Kennan, editor of Interventional Cardiology Review. Welcome to this Radcliffe Cardiology Roundtable discussion of coronary physiology. So in this first section, we will briefly discuss the underlying principles of physiological assessment of coronary arteries and then review the data relating to fractional flow reserve, or FFR. So Andrew, to kick off, could you tell us what it is that a coronary angiogram doesn't tell us that physiological assessment does?
Well, coronary angiogram is, of course, an anatomical assessment. It's served us well over the decades. And traditionally, we would have looked to revascularize a patient with a luminal stenosis of 50% or more. In later years, that migrated more to 70% or more. Increasingly, though, as we understood more and more about coronary physiology, we understand that the priority for revascularization, particularly in stable disease, is to revascularize flow-limiting lesions, lesions that cause ischemia, particularly to a large burden of myocardium. We increasingly understand that the degree of ischemia is the thing that determines outcome, and we can't really measure that just by simply looking at a coronary angiogram unless we have a truly critical stenosis of more than 90%. So what we need is a measure that tells us whether that anatomical stenosis is functionally significant, and that's where coronary physiology comes into play. It can tell us that in luminal stenosis of 50 to 70%, that we used to revascularize on a daily basis, never mind a weekly basis. Up to two-thirds of those may not be flow limiting and therefore may not require revascularization and may not benefit from revascularization. So I think the days of purely relying on a coronary angiogram to assess a moderate anatomical stenosis are gone now.
Eric, you've done a lot of research on this. Do you have anything to add to that?
So maybe one of the comments that we could make at that stage also that probably we will discuss later on, it is to at one point to make the relationship between the ischemic territory and the potential lesion that we have to treat. Because I believe there is maybe a misconception that physiology is purely a measurement of a lesion. It's actually a measurement of territory. It's kind of, let's say, a link between a non-invasive test and the angiogram. But it's not strictly 100% linked to one specific lesion. And it will be part of the issue that we'll have to discuss is how to match what the physiology provides us as an information, as a territory, to the lesion that potentially we could treat.
Okay, thank you. Matthias, could you summarize the theory behind FFR, perhaps just touching on some of the assumptions that are made?
We know that across the lesion that is stenotic, we do get a pressure difference. And traditionally, we know that pressure, we want to find out whether that pressure difference is significant. What does significant means? That means that it's actually flow limiting. And traditionally, this concept was evolved using the flow catheters, and we saw that if you had a significant lesion, in other words, more than 75 to 80%, we usually got a flow impairment. And then some of the seminal work showed that there was an agreement between pressure and flow. And the reason really why this work was performed was because that it's really difficult to do flow measurements. All of us who've done flow measurements realize that it takes a lot of time, so it's not really applicable in a clinical setting, even though you can use it in a research setting. So the traditional work by Nico Pils and Bernard de Bern really showed that there was a good agreement between pressure and flow in most of the circumstances, which really led up to the clinical trials showing that it was superior to angiography.
Okay, good. That neatly takes us up to the trials. Devaka, the DEFER trial, what's your take-home message from that?
Well, actually, DEFER was the first trial to put FFR, or physiological assessment, on the map as a clinical tool. So briefly, DEFER took a group of patients who were due to have PCI based on angiographic appearances alone, and then sub-selected those patients who had an FFR greater than 0.75, because by this stage, I think 0.75 had become established as the ischemic threshold. Those who had an FFR less than 0.75 had PCI anyway, and those who had an FFR greater were randomized to either have medical therapy or to go on and have PCI as the cardiologist had originally intended. And then follow-up was a composite endpoint of MACE. And what that showed was that those who were deferred on the basis of having an FFR greater than 0.75 really did quite well. And in fact, the best outcomes were in that group.
In the deferred group.
That's right. Those who had PCI performed despite having a normal FFR actually did worse. And that's possibly because of complications related to the revascularization itself.
Was that significantly worse?
It became significantly worse as the duration of follow-up went on. So early on, when you were looking at 6-month and 1-year outcomes, it wasn't. But there's now 5-year data out there, and yes, there's a continuous gradation of risk. Those who have a normal FFR but are treated medically doing best. Right. Those who had normal FFR but had PCI doing slightly worse, and of course those who had a positive FFR doing worse still.
Yes.
Whether that's a marker of the disease burden,
indeed,
or the intervention, it's difficult to say.
Okay, thank you. Sergio, FAME, the first one, what's the take-home message from that?
So in FAME, actually the cutoff was raised to 0.80, the ischemic cutoff. And what investigators did was they randomized patients to either an angiographic decision to be made or a physiological decision to be made. Yeah. And what they showed, it was a big study with almost 1,000 patients, was that making your decisions based on physiology is safe. Actually, it seems to be even safer than doing that based only on angiography information. So these patients didn't have more myocardial infarctions. In fact, they had less myocardial infarctions. They didn't have more mortality, and they didn't have more revascularizations if the decision was made based only on physiology, and in this case with an FFR below 80 as the threshold to revascularize.
Yeah. I was reading the other day, at 2 years, there was only one infarct related to a deferred lesion, which is pretty impressive stuff.
And it's very important because one of the idea is still prevalent is that if you leave a lesion without treatment, that may increase the risk of myocardial infarction. And FAME clearly showed that's not the way. It's exactly the opposite. If you put a stent in, then you increase the risk of having a myocardial infarction because of the risk of the new disease you created, and you have the risk of stent thrombosis afterwards.
Yeah. That's not very reassuring as an interventional cardiologist, but
right.
That's a fact. Okay. Stefan, FAME 2.
And FAME 2 was sort of the missing piece that was still necessary, because the deferred trial and the FAME trial, they showed that if FFR shows that there's no ischemia, you shouldn't revascularize. But the missing piece is, should you revascularize if FFR is positive? Because from FAME and defer, you could still draw the conclusion that it's best not to do anything ever. And FAME 2 was the study that then showed if FFR is measured and FFR is less than 0.8, you should revascularize, and you should not leave these lesions alone because you reduce the number of events by revascularization. So that was the missing piece, the positive side of the picture, showing that an FFR of less than 0.8 requires revascularization.
Yeah. Sort of a startling trial when you look back at it, because you're saying, you've got a positive FFR and you're not going to treat this. But excellent results. Yeah. There was a bit of controversy about how significant the different outcomes were, but I think ultimately there were, in terms of urgent revascularization, as sort of slightly soft endpoint. But I think it was, even if you sort of drill down to the people who were troponin positive and ischemic ECGs, there was a significant difference between.
There is a significant difference for these outcomes. There's still the Achilles heel, so to speak, is that we don't have mortality differences. So no trial showed a mortality difference. But for other outcomes, such as urgent revascularization, there is a significant difference.
Okay. So that's the randomized data. Eric, I think you're one of the investigators on the R3F Registry, and we sort of venerate randomized data, but this is quite an important registry, I think.
Yeah, we could maybe discuss a little bit more about it later, because it's one of the first registry investigating one of the questions. But as it comes now, additional registries have basically confirmed the information of the R3F Registry. So just to explain a little bit the design, the question was to understand how physiology, in that case FFR, was impacting the decision of the physician. So in the design of the study, basically physicians were asked to provide a first decision without having the FFR information. It was based on the patient history, results of non-invasive tests, and the results of the angiogram, and they had to provide a decision. That this decision could be either optimal medical treatment, PCI, or revascularization, or bypass surgery. And then again, the physician were asked to provide the same answer once the FFR information was available. And the first piece of information that we could see is that the crude number of the proportion of patients referred to medical treatment, PCI, and surgery were about the same between before and after using the FFR. It was a little bit less PCI, a little bit more medical treatment, and about the same number of surgery. But what was striking is that between without the FFR and after, then there was a strike change for every individual. It means that in about 1 out of 2 patients, the initial decision without FFR was changed by using the FFR. So it was really the first time that we could show that by using FFR, you impacting on an individual patient basis the decision for a patient. So again, it was the first piece of information, and to demonstrate the impact of FFR on the medical decision process. And again, the second part of information was again about reassuring physician about taking a decision against the angiography. Because as we discussed, when the FFR is just saying the same thing that the angio, nobody has a problem to follow the decision. But when the physiology tells something that is opposite to the angio, what does happen? And in this registry, we were able to have 2 major groups. One group were of patients where basically everything was on the same page. That is basically FFR and angio agrees. And that group was reference group, considered to be the group behaving well. And then another group was where basically physicians followed the FFR, but the FFR was provided a decision different from the angio. And we want to reassure again, if you take a decision against the angio, whatever this decision, could be a defer, but an infer decision that say, I do a PCI, while the angio say, don't do anything, to show that indeed in that case, the clinical outcome, including hard endpoint, was similar to the group where everything was on the same page. So it was reassuring for the physician to say, okay, you can follow the FFR against the angio, and we have the same good outcome than when FFR and angio are on the same page.
Thank you. And an important part of this trial, I think, is that unlike FAME and DEFER, where all of the patients, it had already been decided they needed PCI, the important part of this was anyone with over 30%. Was that right? The population was any patient who had a narrowing of 30% or more. So that's a very different population from the randomized trials.
You're absolutely right. And again, in that registry, the patient, when the angio was done, when the FFR was done, it was not a population where the decision to do a PCI was already done, actually. And if you come back to the DEFER, to the FAME, or to the FAME2 study, basically, before the patient entered the trial, the decision was already done to go for a PCI, which is very different to our current practice. Our current practice is we do an angio, and we want to use FFR to help us to decide what is the best treatment. Again, the DEFER and FAME were very interesting, but it's very different from our current practice. And it was also very important to demonstrate that the way you use it in the real life, that is that you want to use FFR to help you to get the best decision, you could validate that in the real world.
Okay. The other part of the paper that I found quite interesting was how they demonstrated what predicted a positive FFR and what predicted a negative FFR. Can you just take us through a bit of that?
Again, it's about one of what Andrew was telling before, and I was a little bit before. We were looking at the predictor. What can predict an FFR to be positive, and including in that potential model, we included the percentage of stenosis. Mm-hmm. And actually, indeed, the percent stenosis was a predictor of FFR, but it was one of the worst one. Some other predictors were more powerful than the actual percent stenosis to predict what will predict a low FFR value. And we were able to see that something that we know, but we could demonstrate that if you have everything being the same, a lesion on the LAD, you have more chance to get an FFR positive. If it's a proximal lesion, you have more chance to get an FFR positive. If you have a long lesion, you have more chance to have an FFR positive. If you have a complex lesion, you have more chance to have an FFR positive. And the worst one was the percent stenosis. So meaning that indeed, to understand how an angiogram will impact the FFR value, you have to take into account a lot of parameters beyond the percent stenosis.
Yeah. And that sort of explains those readings where you're thinking, I hadn't been expecting that, I'd been expecting it positive or negative. In fact, it's all explained by that sort of data. Exactly. Andrew, other registry data?
Well, we've got quite a lot of data now from the group who are developing IFR, surprisingly. So they've collected a lot of FFR data in parallel. So just coming on to the severity of the FFRs that were in those trials compared to the real world. So within FAME1, the average FFR of an ischemia-causing lesion was 0.6. Now, we don't often see FFRs of that sort of level in the real world because we tend not to bring out the pressure wire to look at a lesion that we think of that severe. In Advising Practice, which was a real-world registry of looking at FFR and IFR, we found an average FFR of 0.81. Now, that chimes more with people's experience of using coronary physiology, and I'm not sure what the average FFR was in R3F, but I imagine it was closer to 0.81 than it was to...
So it's 0.82.
0.82 than it was to 0.6, because personally I always feel if my average FFR value is 0.6, I'm probably using too many pressure wires. But so we are increasingly seeing that FFR-guided practice for intermediate lesions has merit both in terms of patient safety, in terms of improving symptoms, and cost efficacy. We are reducing unnecessary PCIs. We are selecting the right cases. We are preventing patients going to surgery and having thoracotomy unnecessarily for 3-vessel anatomical disease that is actually only 1 or 2 vessel functional disease.
Yep.
And I think all the real-world data is pulling in the same direction as the randomized trials. I don't think we're seeing conflict here, that this is a good technology that improves what we do.
Okay. Stefan, does the registry data tell us anything about what the cutoff point should be? Is 0.8 the right cutoff?
Well, I think that's one problem we might have in FFR, that everybody is thinking of this one single cutoff. But of course, in physiology, never is anything 100% accurate or one single threshold to work with. I mean, the trials have given us these two cutoffs of 0.75 and 0.80. But had some other scale been used, we would probably be using a different threshold today. And we should not forget this when we have an individual patient to treat. For example, the patient who has angina but has a FFR of 0.81. Does this mean that we should definitely not do anything to this patient? So I think there's more work that needs to be done to better understand what threshold should be picked in the individual patient. Okay. But currently we have the data to work with. Yeah. And these are single thresholds that have been given to us by the randomized trials, single thresholds that are contained in the official recommendations, 0.80. So these are the thresholds we have to work with, but we have to be aware of the limitations.
Matthias, 0.67 is a threshold that keeps coming back in the literature as sort of the most efficient threshold.
Well, I think it's, I just like to mirror what Stefan said. I don't really believe in thresholds. I think thresholds is really something, data which you pick out of clinical trials. If we have threshold 0.67, Nils Johnson showed that this is really when the amount of hard endpoint starts to rise if you defer the patient from PCI. However, I don't think really that's the way we should, or the way we actually use physiology today. We typically use it for intermediate lesions, and yes, we do find the 0.67 FFR values in those lesions, but they're actually quite rare. So it's not really a practical standpoint. For me, I would rather say that between 0.75 or 0.67 or below, we start to see an increase of events. So we can use that information to actually defer the patient if we don't want to use the lesion. So we can use it as a stop sign for clinical judgment. And everything above 0.75, we can use our clinical judgment instead. Does the patient really need this? Does the patient have symptoms? But as we start going below 0.75 or 0.67, we should really have an extremely good reason for deferring the patient. This is really, I think we should use cutoff points.
Okay. Stefan?
Just to mention, the problem of single thresholds is, as far as I recall, there's data that if you have done a PCI, and you measure FFR after PCI and it's less than 0.9, you get events. And so after PCI, the FFR should be better than 0.9. So just to indicate that there is not one single threshold that you can use for every situation.
Yeah, okay. Devaka, economics. What does the data tell us about the economic implications of pressure wire use?
Well, interestingly, it seems to suggest that it may, in the long run, be a cost-saving technology. Of course, there's a cost of doing the pressure wire. There's a cost of adenosine, and we'll come back to that, I'm sure, later in the discussion. But all of the registry and trial data tells us that we are actually putting in less stents, treating less vessels that might have otherwise inappropriately been treated. So, you know, in the long run, it's thought to be a cost-saving technology, not just at the time of the procedure, of course. We've just spoken about those patients who are deferred having the best outcomes and less further revascularizations, less readmissions, etc. So actually by choosing the right patient and the right artery to treat, we'll reduce those subsequent MACE-related costs as well.
Yeah. I read somewhere that the cost of a QALY after PCI and FAME2 was $36,000, and the cost of a QALY in Courage was $300,000. So I think that gives you a good idea of the efficacy of physiological assessment. Sergio, what are the downsides of the pressure wire? Not its limitations, but complications related to its use?
Well, mainly the complication, besides the complications you may have because you put a wire in, but those are very rare. In the registries, you have 1 or 2 cases in more than 1,000 patients.
Yeah.
The main complication is related to the fact that you need to give adenosine if you measure FFR, and there are some side effects with adenosine. Some side effects that may be symptoms that may be problematic for the patient, and also side effects related to the drop in blood pressure, and that may be important in some cases, and actually it may even lead us to a wrong diagnosis, because that effect in blood pressure may eventually lead to a wrong conclusion in the FFR value.
Yeah. Okay. So the CVIT defer registry, I got 0.3% complication rate. Does that fit with your clinical, what you feel is happening in your clinical practice, Andrew?
I'd be surprised if it was that high.
Oh, really?
I mean, of course, whenever you come into clinical trials, you get a slight bruise on a leg somewhere and it comes down as a complication, and that's right within clinical trials. But in terms of serious complications where you regret doing the procedure in the first place, is vanishingly rare. I mean, this is a very safe procedure. I would say diagnostic angiography is more dangerous than putting a pressure wire down, because it's that intubation of the left main that causes more problems than passing a pressure wire down a straightforward LAD. Of course, if you've got tortuous disease, you have to be careful. The modern pressure wires are really excellent engineering, and they behave very much like the old BMW wires. So one shouldn't willy-nilly tackle a highly tortuous shepherd's crook right coronary artery without considering carefully whether it's required. But I can't think of a dissection I've caused with a pressure wire in the last 5 years. I can't think of a thrombotic complication. There's much more risk putting a guide catheter or a diagnostic catheter into a left main or a right coronary, in my opinion.
Yeah. Again, going back to the sort of registry data, they're saying that the most frequent complications are arrhythmias, which doesn't fit with my experience at all. I can't remember an arrhythmia as a result of a pressure wire.
Of course, you might get a bit of heart block with adenosine, particularly if you're giving intracoronary adenosine into the right coronary. Yeah. But this is a transient effect. As long as your patient is non-dipyridamol, it passes within 5 or 6 seconds, and it's clinically irrelevant. Of course, it may affect your result. You might have to reduce the dose, do it again, or use intravenous adenosine in that circumstance. But serious arrhythmia is vanishingly rare.
Okay, thank you very much. So that's a good base for us to go on to the next section. In summary, it's clear there's a wealth of randomised and registry data supporting the use of FFR to assess coronary artery narrowings, consistently demonstrating its use improves outcomes and reduces costs. Thank you.